to have folks joining this ECHO series. This is the second part in a three-part ECHO series this summer that we are so pleased to present. And I want to introduce our speakers for this series, Julie Wiedauer and Erin Beaver. Julie will be presenting the didactic portion today. She is a certified genetic counselor and has over 9 years of experience in genetic services in a laboratory, hospital, and health plan vendor setting. She is specialized in, need a second, let me get this out of my way. She specialized in utilization management to increase access to appropriate genetic testing across the healthcare system. Her passion lies in speaking enthusiastically and effectively to multiple stakeholders while advocating for increased access to quality genetics care and forming partnerships between providers, institutions, health plans, and laboratories. Erin Beaver is also joining us today. They are alternating throughout the series in terms of who presents the didactic, but they work very well together to collaborate on the case presentations along with the didactic. Erin is a genetic counselor with 1 year of industry experience and over 9 years of clinical experience in the St. Louis, Missouri area. She's the founder of Ingenuity, LLC, a genetic genealogy and counseling company. Erin currently works as a full-time clinical genetic counselor in oncology at the BJC Healthcare Missouri Baptist Medical Center Breast Healthcare Center. Previous to this position, she held an industry genomic testing consultant position with PerkinElmer Genomics, which is a clinical genetic counselor and genetic counseling supervisor position at Mercy Hospital in St. Louis, and a clinical genetic counselor position in fetal care at Washington University in St. Louis. In her free time, Erin teaches at the Washington University in St. Louis Genetic Counseling Program and advises thesis students at the UAMS Genetic Counseling Program. Erin's research interests include development of innovative models of care in genetics, public health communications, and addressing inequities and disparities in healthcare, especially as it relates to genetic services. I just want to orient everyone here to the way the ECHO series works, or an ECHO set works. Those of you who were on last time, you're getting a refresher here. But basically, the Project ECHO model is a model for education. And attendees bring their experience to this discussion. And so part of what makes the ECHO interesting and different from a webinar is that as the cases are presented, we actually want to hear first from the participants. What are your questions you have about the case? What would you do? Because you're bringing different areas of expertise to this discussion. So we want to hear from you. And then the quote experts will weigh in with what questions, what they might do. But this is an all learner platform, if you will. And so we do welcome and invite your participation throughout. And so at this point now, I will turn it over, I believe, to.
Great, thank you so much, Lori. A little bit of housekeeping before we get started is that we want to make sure that there's a lot of clarity around all of the ECHO planning teams, relationships and disclosures. So as you can see, those are presented here. And as for Erin and myself, I'm an employee of and hold stock in my employer, Guardant Health, which is a cancer DNA testing laboratory. So not terribly relevant to the content today, but want you guys to be aware. And then Erin was a previous employee of PerkinElmer Genomics and had an ownership interest in Ingenuity. So great. And then this presentation today does have the ability for the AMA educational kits. So for a category 1. And for the genetic counselors on call, this also has been approved for CEUs. So the I know there'll be some housekeeping at the end, I think, to guide how attendees can register and get that educational credit. Great. So essentially what we're hoping to do is really review. We talked in the last ECHO session about how do you get to genetics? And now we really want to identify and discuss what happens when you're at genetics and genetic testing is on the table. There's so much disparity between what actually has to happen behind the scenes and what might be apparent to other providers or families. And so we really wanted to demystify that process and highlight and learn from you all how we can move through this process efficiently. So the basis of ECHO sessions are really these case models. So I wanted to review one of the cases that we've continued through our discussions. So in case 1, we're thinking of a typical presentation that we might see in genetics. So a 5-year-old boy with a concern for autism and a history of speech delay. And growth parameters are on the bigger scale. And so there might be some clues in the physical presentation and family history of underlying genetic syndrome, but also we think about, a referral for autism or developmental delay is one of the most common referrals that we'll see in pediatrics. And so that was the basis of the case. And we talked last week about how a family like this might benefit from a genetics evaluation and how they might get there. But now we're going to kind of evaluate, okay, once we get to genetics and some genetic testing is indeed indicated, how do we go about securing that? And so for our case 1, we're going to kind of assume that the patient is covered by Medicaid. And to make it relevant to our Heartland region, we're going to assume that they're covered by Missouri Medicaid. And I can kind of take a stab at if they were covered by Arkansas Medicaid, what that might look like. And so I'm wondering from the attendees today, does anybody want to hop off mute or type in the chat? If we wanted to do some genetic testing for this patient with Medicaid in Missouri, is that something that we think would easily happen? Is this something that's going to be a laborious process, or do we feel like it's straightforward? Do we think the family is going to end up seeing any bills, or because of Medicaid coverage, are they somewhat protected? I'm really hoping someone, hops off mute, lets me know what's your experience with Missouri Medicaid.
Julie, I can give you some insight as to what I experienced whenever I was in clinic. So in Missouri, we have straight Medicaid, as we call it, like in the sense of like, it's just Medicaid. It's just your basic Medicaid. But then we have managed care plans. And I think where a person resides, that determines which of those options that you have available to you. The managed Medicaid plans are very similar to a lot of your private insurances because they are managed by a lot of the private insurances. And then the MoHealthNet Medicaid has a little bit of a different process. So I think one of the things is that depending on the process could be different, whether it's the MoHealthNet versus whether it's one of the managed Medicaid plans. Typically, we had to get predetermination or prior authorization. Prior authorization, you see more with the managed Medicaids. Predetermination, we saw more with the MoHealthNet. And it depended on what testing that you were doing, whether or not it might be covered. So like Fragile X, I felt like got covered very easily. And so that might be one of the things that we would want to do testing for in this circumstance. I would say even microarrays had pretty good coverage. And I think it's important to make sure that you're working with a laboratory that would accept Missouri Medicaid. So that's something that if people are unfamiliar with ordering genetic testing, they would want to make sure with whatever lab they're using that it is actually covered, or there's a contract in place for Missouri Medicaid.
Excellent. And every state treats Medicaid coverage very differently. And so I'm going to put Braden on the spot. If you're able to either hop off mute or type in the chat, how is Medicaid handled down in Arkansas? Most of the kids will filter through Arkansas Children's Hospital. And how would, Fragile X, a microarray, or even an autism panel work in the Arkansas?
We may have lost Julie. She may have frozen up there, but if Braden wants, okay, so Braden says similar to what I said. So it sounds like some things are covered a little bit better. Okay, so Fragile X and microarray are pretty well covered under Arkansas Medicaid. Do we have providers from other states that would like to share what their experience has been with their state Medicaid? Braden, can you speak to like panels for autism or whole exome? I know that it was hit and miss. I don't think Mo HealthNet that they would cover a lot of the like panels, or definitely not exome. It would be very difficult to get that covered. But managed Medicaid was a little bit better. Okay, and Braden points out that his clinic works very closely with the labs to make sure that there are contracts in place with Medicaid. All right. Anybody else want to speak to their experiences while we're waiting for Julie to rejoin us? I can share. I can go ahead and
Erin.
move on. Yes.
Erin, I'm sorry, it was taking me a minute to unmute. So I don't want to put, oh no, that's not, yeah. So Mimi or Joyelle, you may not. Oh, Darlene's on. So for the North Dakota folks, I know that at least years ago, I do not know the current status now, but I know years ago, there, at least for some patients in North Dakota, were difficulties with genetic testing coverage. I don't know, like I said, I don't know the status now. Maybe it's resolved. Can any of you comment on that with and I don't know if the difficulties were on the private payer side, families that had employee health insurance, or if it was on the Medicaid side. So Erin, I apologize if I'm sidetracking here, but I'd like to hear from North Dakota if they don't mind sharing.
Joyelle, do you want to talk or do you want me to talk?
Whichever.
But so in my follow-up, we have found that some patients are having difficulty getting coverage for the genetic testing because North Dakota doesn't have an in-state, in-network laboratory to process those. And because our numbers are so low, many of the out-of-state laboratories don't want to enroll as Medicaid providers for the state of North Dakota. And then another issue that we've found with that is the delayed billing. So families will get the bill maybe 7 or 8 months later, which then it's over the time frame that our special health services could cover that, even though it can't be paid by Medicaid or it can't be paid by somebody else. Usually we can gap fill in those circumstances, but it has to be within 90 days. And so those are some of the instances that we've ran into with getting that coverage. It's been kind of interesting. We have gotten letters of prior authorization, but then in small print at the bottom of the letter, it'll say, if this test is conducted out of network, we will only cover $5 of the testing or whatever. And it's been missed by the family, the provider, and maybe the testing site doesn't care because they're going to get paid one way or the other, right? But the parties beforehand didn't catch it, and so then it gets billed, and then the families are stuck with that testing.
And we have had some additional challenges because, like, from age birth to 21, our special health services division, we can help to gap fill some of that if they qualify financially. So if they want to do any parent testing, genetic testing, then we can't help cover that. And so those are a lot of the circumstances and the situations where they reach out to us and ask us if there's anything that they can do, but like we can't pay for anybody over 21 for genetic testing, for any diagnostic testing or anything. So that always poses challenges.
We do have a medical geneticist who is very thrifty and able to find less expensive ways of doing genetic testing, and is very astute at finding like what's the least expensive for out-of-pocket costs for families. And so she does a lot of that with them. She'll work with them to get certain things that way. And then there is another thing that they've done a few times where the hospital will actually pay for the service, and then the family will, then they can bill insurance, the hospital can. It's been done a few times. I don't know how successful it is, but I know that they've done that where the hospital pays up front and then they bill that through insurance. So it's a service through the hospital. So.
Great, thank you. And I just want to clarify, well, first apologize for the lapse in internet. I think we should be connected on my side. Are we on case 2? Did we move over to commercial insurance? Okay, great. Great. Yeah. And so we have similar experience down in Arkansas as well, where it really is plan dependent. I think a key emphasis for this is it is very dependent on what the commercial insurance is and what their policy is. So we'll talk a lot today about how providers and families can participate in this process. Great. So this is some content we didn't quite get to in our last ECHO session that we feel like is really great to reframe. Okay, we're pretty sure genetics is needed for these kiddos. You know, how can we go about making this as smooth and helpful as possible? If you're a provider referring a patient or family to genetics, there's a lot of information that you can give that really helps the family's experience and the genetics provider's experience so that it can be maximally efficient. Letting us know why you're sending them to us. The indication for referral is very important. And all the relevant records, you know, we can definitely try and get that ahead of time, but it's really helpful to either send with the patient or send over ahead of time. What medical history, what developmental assessments, what laboratories have already been done so that we don't have to poke kids over again if we don't have to. And then definitely most practices will take stock of what insurance is being applied, but many times there's multiple insurance. Maybe your physical therapy office only takes a certain kind, so you only, you know, have the commercial insurance card, but maybe the patient is covered with Medicaid too. So if we know all the insurance is in play, we can really understand what testing options are available. And then of course the family history. And it's really helpful to set up expectations with the family, with the patient. We're sending you to genetics. We think this is a good idea. What other information can we share to make this, you know, seem relevant to you guys and to make this go as smoothly as possible? So Erin and I put our brains together and we thought, okay, what do we want patients and families to know before they come see us in genetics? I think it's really helpful to explain to the family, okay, learning or movement isn't progressing as much as we thought or as much as we'd hoped. And so we just kind of want to investigate whether there might be an underlying cause of that. This helps avoid the uncomfortable situation of us in genetics talking to the family about, what's your understanding of why we're here today? And they're like, I don't know. I was just told to come to an appointment. We want to start off on the best foot possible. And a lot of times it's helpful to say, like, what can you expect from a genetics appointment? They're going to ask you about symptoms, probably retread a lot of the ground you've already talked to other doctors about, but they might ask more detailed questions, particularly sometimes in, our family history assessment. It might feel like we're asking nosy questions. So it's helpful to kind of set that stage that they might be asking detailed or kind of weird questions, but it's all for the purpose of looking for clues. And it's really helpful for a referring provider to talk to the family that I'm sending you to genetics. Sometimes they do DNA testing, but not always. Sometimes we have families come to us and they expect I'm here for genetic testing. And that can kind of create a little bit of tension if genetic testing ultimately isn't the most appropriate thing. Or if they didn't want genetic testing to begin with, there's still a lot of valuable information that we can cover together outside of the testing process. And there are great materials that help support what to expect, what might happen in genetics. And those are written and provided at a language or cultural appropriate level. So when someone gets to genetics and we decide genetic testing could be helpful for a family and they agree, there's a lot of variance in who might coordinate this. So depending on the service model, which we're going to talk about in our different cases, we'll talk about what kind of providers might help coordinate genetic testing. It could be a genetic counselor, it could be a nurse, it could be their pediatrician, it could be a developmental medicine doctor. There's such great support that comes from our administrative staff. A lot of times these are the folks helping go through some of these administrative processes like prior authorization or billing, claims, handling appeals. And there are a lot of ways that families or the patient can actually participate in the genetic testing coordinating process, which might, we don't love the idea of having to put more onus on patients and families. So providers and administrative staff are definitely here to do that. But for many families and many different practices, there can actually be great synergy and move through this process a lot more easily when the family is aware and participatory. So I wanted to review from last week. We talked about different models of care, like how are we getting identified that someone might need genetic testing? And if you think of the case number one, you can think of this is a kid with developmental delay, possible autism. And this triage model could be very, useful, particularly where there's not a whole lot of genetic services. So we might have a primary care specialist that identifies, oh, I've got a kid with developmental delay. I know that recommended testing is pretty simple and straightforward. We want to maybe do a microarray as a first tier test, and anything more complicated, I'll send them to the genetics team. But in my practice, I've worked with the genetics team at the local hospital. I've talked to the genetic counselor. We've worked out what testing is appropriate for these common indications like developmental delay. I'm pretty up to date on these guidelines for if we find something, what do we do? And I know if it's anything more complicated than that, I'm going to send it to genetics. So I feel comfortable as a pediatrician, as a developmental specialty nurse, I feel comfortable ordering this first tier of testing myself. I'm wondering, of the attendees today, does anyone follow kind of this model, or what would be the barriers of following this kind of model? Are you referring to genetics for everything, or do you feel that there's any genetic testing that you kind of can confidently order on your own? Does anybody practice this currently? Is everybody pretty much sending to genetics? Feel free to type in the chat too. Let us know how it's working for you guys. One of the barriers I think that we might identify in this model is, and it sounds like Terry Jo from Combined Brain is really trying to encourage, let's move this outside of such a centralized process. One of the things that can be really scary in this kind of model for some is the process of navigating insurance. Nobody wants somebody to get stuck with a bill. So we'll talk about how someone outside of the genetics team can actually leverage these processes. And then in case number 2, we had a patient that looks like they might have a genetic syndrome, specifically something called Stickler syndrome. And this would be something that perhaps, primary care or the patient's local ear, nose, and throat doctor said, okay, there's something going on here. There's a family history, and it's a little more complicated than a straightforward cleft lip and palate. I'm going to refer them to the genetics team. And in this model, the genetics team would facilitate, identify, and handle genetic testing largely. So what are the steps involved in that? Oh, and it sounds like North Dakota is also doing a mix where we have some of that triage model there too. Awesome. I feel like there's really great opportunities, especially if we can get comfortable with this test coordinating process. So first we have to select the testing. In a triage model, if you didn't feel comfortable selecting from the numerous labs out there, you could refer to your genetics team and say, who do we send this very common test to? And understand more about what's the best test to use there. In a refer to genetics model, we are often doing that. We often know, okay, this is the best lab for this indication or this insurance. But selecting the particular test is really important to not go overboard or undercut our ability to arrive at a diagnosis. And then we investigate and advise on insurance coverage. We'll talk about that today quite a bit. Then there would be a decision on testing. We are not forcing anybody to pursue testing if that's not a good fit for them. But what we're able to do is say, this is what testing might give us, and these are the risks associated with testing. So it's really all that specialized math that each family might make in their own dynamic. And then ideally, once that testing has been performed, you would follow up with results. Now, depending if this was clinical genetic testing or through a research program, this time window of getting results and depending on the test itself could be very short. Most of our microarrays at Arkansas Children's came back within a month. But if you're sending out for a more complicated test like exome sequencing, it might be several months. And I've had some research tests take a very long time, might be 6 months or up to a year. And the way you get those results is different depending on the model of care you're pursuing. So here I want to talk about a couple of terms that it's really helpful to know. And there's a great toolkit and discussion of this glossary of terms through a group called Plugs up in the Pacific Northwest. And they have a patient-friendly toolkit, including these kind of terms. So I always find that to be a really helpful reference. So I'm going to kind of go through some of these pretty quickly, and I apologize because my notes are minimized. So I'm going to do my best from just my ingrained knowledge. But a covered benefit would be something that is included in your specific employer covered health plan. It doesn't necessarily mean it's going to be paid. It means that genetic testing is a covered benefit. Some health plans, your employer, to save on a premium, might say, we're going to cover everything except for genetic testing, everything except for cosmetic surgery. That's a very common coverage exclusion. Genetic testing used to be a very common coverage exclusion. But this is the first step that I usually take in the investigative process, is call up the insurance or check the insurance online and make sure that for this specific patient's plan, those prefix at the beginning of the plan number, is genetic testing a covered benefit? If it is, then we proceed with the rest of our investigation. If it is not a covered benefit, then we can't expect insurance coverage at any level. The CPT code is a unique code that identifies a particular genetic test sometimes, but there are different tiers of specificity. Some of our CPT codes can actually apply to hundreds of different genetic tests. Some of those might be in network, some of them might be out of network. So CPT code is something to provide insurance to let them know with a little bit more specificity what genetic testing we're looking for. Coinsurance and copay should be pretty familiar terms with us all, in that is the amount that the member or the patient or the family is responsible for paying. This can be a breakdown according to the plan design. Maybe you have a 20% copay for any covered service and insurance pays 80% until you hit your deductible. So if it's January and you haven't hit your deductible, which is a set amount that the member might be expected to pay before insurance coverage kicks in, if you haven't hit your deductible and we're ordering a $7,000 genetic test, even a 20% coinsurance or copay on that is going to be significant for a family. So this is an important part of understanding what your health plan specifically is through your employer and what the financial out-of-pocket might be. ICD-10 codes are diagnosis codes that providers use to tell insurance, other providers, and basically all the healthcare systems what the reason or diagnosis is. And the more specific and more plentiful we can be with those codes, the better. But usually we have to provide more than just an ICD-10 code because maybe the diagnosis is more specific or nuanced than that. Very interestingly, and can really throw some wrench in the systems. We've already talked about it today, in network and out of network. Perhaps this test is covered. Perhaps we've gone through prior authorization and it's found to be medically necessary. Those would all be green flags that we're not going to get a big bill. But if we are sending to a lab and that lab is not an in-network benefit for this particular plan, then depending on the benefit structure of that plan, the patient and family might actually have to pay out of pocket for using a lab that's out of network. Sometimes there are, remedies to this by arguing that there wasn't anything in network that you could use, but a lot of times this can be a source of surprise bills that I think you guys already talked about. Unless you're really paying attention to it, this is very nuanced. And then we have our max out of pocket. Sometimes once you reach a certain amount that you've paid for the year, everything else is covered by insurance. That's why our clinics get really busy in December. And then some of our health plans can offer prior authorization or predetermination. Both of these are kind of giving an answer, but not guarantee that before we do the testing, how likely is it that it would be covered or paid for or considered in alignment with policy. Neither of those are guarantees, but certainly a prior authorization streamlines the process. So one thing to know is that there's a hierarchy of those covered services. It's in the contract. But just because something's covered does not necessarily mean it will be paid for. If it's covered and the health plan has a medical policy and says, we will pay for this test when these criteria are met, then we must, go through prior authorization or advise the patient, I think you meet policy. So just because it's covered, a particular test or patient's presentation might not meet policy, and we want to be conscientious of that. I'm going to skip ahead a little bit and just breeze through these processes so that we have time for discussion. When you access a commercial insurance policy, it's pretty easy to do. Kind of Google Cigna microarray policy, or Cigna genetic testing medical policy, UHC medical policy. A lot of them will be displayed on their website. And what I do is if I see the same insurance a lot, I'm going to just dedicate half of an afternoon, go online, print off all these policies so that I've got them ready. Then you would call the insurer and see whether all of the CPT codes for the test you want to use are covered. So if I'm doing this in a primary care setting, I might call the insurance and say, I want to do a microarray as a first tier test. The CPT code is 81229. Is this covered? And they would say, yes, this is a covered benefit. And then I would look at the policy and I would say, okay, my patient has developmental delay. We should be good. Sometimes, depending on the test, you'll see that they have a policy where there are no criteria for medical necessity. Instead, it says this test is considered experimental, investigational, unproven. These are very scary words for patients and families to see, particularly if something's denied, because they might think you're ordering something experimental. But what this language means in health insurance land is that there's not enough scientific evidence to say that this test being used for this kind of patient makes them healthier. So we know in genetics in particular, there might be a lot of value and benefit to arriving at a diagnosis that doesn't necessarily make the person healthier. We can get a lot of good knowledge from these diagnoses without having to change medical management, although that is a very common thing. But some of these healthcare policies may not acknowledge those other benefits as being worthwhile. So if you see experimental, investigational, or unproven in a policy, can kind of know, no matter how compelling I think this is probably not going to be paid for, and then advise your patient as such. And so when prior authorization is offered by a health plan, usually when I'm calling, I'm asking, are these codes covered? And then is prior authorization available? You can submit the information for the patient, and every health plan kind of does this differently. It might be faxing a form. It might be sending a letter with medical records, or you might have to log on to a portal and click through questions. But when those prior authorizations are offered, if you go through it, you'll usually end up with a yes or no answer, and you can feel pretty okay about telling the patient what to expect in terms of whether or not this might be covered. But it is very plan specific as to what they might end up paying out of pocket, because co-insurance, out-of-pocket maximums, and deductibles. And so I'm wondering, rather than rehashing the authorization process, as you guys are kind of exploring prior authorization in your clinics, how are you handling those conversations? If you get a letter that says this is prior authorized, prior authorization granted, what does your conversation with families sound like? For me, back in the day, it would have been great. They have reviewed the information and found that it meets policy. This is very likely to be covered and paid for. And the details specific to your plan mean that there might be a variety of out-of-pocket costs. And unfortunately, I can't tell you exactly how much that will be. What does everyone else's conversation sound like? Erin, how did you talk about this with families?
So interestingly, this was probably the #1 reason why we got phone calls into our office, was to talk through insurance pieces. And so one of our genetic counseling assistants developed this half sheet of terms like what you shared here, just kind of defining some of this vocabulary around insurance. And also she had another half of the sheet, so it was really one page altogether that outlined the process of prior authorization, and also like the expectation that having your test covered by insurance does not mean that there's zero cost, that you have, you may have a deductible, you may have co-insurance. And so this full sheet altogether, I don't know if I still have a copy of that because I've been out of peds for a year and a half, but I'll see if I can contact that clinic if they're still using that to Amy. But yeah, we used that and we presented that to the patients when they scheduled their genetics appointment. So it was with their intake information. We actually discussed it in genetic counseling. So I'd say, remember that sheet of paper that you got whenever you scheduled your appointment. It explained this information. I encourage you to, refresh your memory with that as we move through this process. So then we were not having to re-explain it every time. Obviously, when we were calling patients to tell them, oh, we've got the authorization in place, you can go get your testing. Sometimes these questions came up and we would answer them and review that information. But that is actually a really great tool that we should probably add to our toolkit, Julie, now that I'm thinking about it. But that's how we handled it. And it made the conversation more smooth and gave them a reference.
Mm-hmm. And so I'm going to skip briefly past the elements of a letter of medical necessity. Through this prior authorization process, sometimes you'll be asked to justify why this test is necessary for this patient. And writing a letter of medical necessity is a great way to support that conversation. But I wanted to highlight too, whenever you're doing a prior authorization, gathering this initial information and even training your administrative staff who are supporting or assisting, you can really offload a lot of this burdensome process if you or your office staff are trained to proactively gather this information. You want the insurance and demographic info, CPT codes, ICD-10 codes, any relevant medical history information, and also laboratory information. They want to know where you're sending this so that they can help support whether it's in or out of network. And in that letter of medical necessity, I will just summarize all of this information and say, you can give a 5-page letter, and as a former insurance reviewer myself, it largely might not be read or useful. Meanwhile, I've seen paragraphs provided that tell me everything I need to know. Why this test is necessary for this patient, how you plan to use the information, will you start or stop medicine? Will you start or stop a specialist referral? And then what test specifically is being requested. So this is something that families justifiably may struggle with. Why can't you just tell me how much this is going to cost? And that's because there are a lot of different mechanisms in place that impact what may ultimately be on a bill. First, there's the list price, what the lab actually posts maybe on their website or on their fee schedule. And then there's the billed price, what they might actually pass to insurance. Usually this is going to be higher than the list price because they anticipate insurance not paying all of what they're asking. So you might see a $7,000 test billed to insurance for $20,000. And I have seen it many times. Then there's a thing called markup. If you're sending a test through a clinic or through a hospital, that hospital might actually raise the price 25% or so. And that helps cover the process, the costs, and also gives a little bit of profit to that institution. So markup is something that we might anticipate impacting a final bill too. And then your deductible, depending on the specific plan, you might have to pay co-insurance or copay. You might have to pay or meet a certain amount of out of pocket or a certain deductible before insurance kicks in. And all of that is very specific to your particular employer's plan. And so it's kind of hard when you're one provider who sees 12 patients a day to know the ins and outs of every specific health plan. We are pretty good about knowing the broad strokes, but what might actually come down to the out of pocket is a really hard thing for us to guarantee. So I would often say, worst case scenario, nothing is covered. We might be looking at $1,200, $2,500, but I feel pretty confident that based on the information we have, it's not going to be that, but I want us to move forward eyes open. And then I think most providers on the call might recognize this explanation of benefits as kind of the dreaded confuser of all patients. So often a health insurance company will send the patient directly an explanation of benefits, what was billed to insurance, what was paid by insurance, and what still remains, although we're still going through the process. And I totally understand. In fact, I have done this to my own providers where it says explanation of benefits. Many of them at the top specifically say, this is not a bill. But when you see $40,000 or $20,000, there's no way to your brain short circuits. So especially I wanted to equip any of our non-genetics providers. If you guys are thinking of using that triage model, or if you're working with a patient advocacy group and you're advocating for that triage model, being familiar with some of these pitfalls can really help equip providers to navigate this process versus, man, if I'm a pediatrician and somebody called me and said, I just got a bill for $20,000, I know I would freak out. But as a genetic counselor that's gone through this process a lot, one of the first things I'll ask is say, what does it say at the top of the form? Explanation of benefits. Great. This is not a bill. This is not saying you have to pay that. And being prepared to have that conversation can really help make sure that not only those of us who do it all day, every day are comfortable. In terms of actually getting the genetic testing done, there's actually a few different ways that we can go about collecting specimens that have DNA in them, and a couple of pitfalls that might make a particular practice more or less likely or comfortable with going through this process. First, and probably most reliable, wouldn't you say, Erin, is a blood sample.
I would say, yeah, it is pretty, it's the most reliable, but I will caution that if you're not drawing that in your clinic as the ordering provider and you're using a lab, like the outpatient lab at your hospital or a phlebotomy service, it can be an additional cost to the patient. So something to be aware of.
That's such a good point. Yes, want to be aware of the phlebotomy process and costs, but blood contains the most easily accessible DNA, and usually about a teaspoon is what would be drawn. But we know that there are a lot of individuals for whom a blood draw is not convenient or not pleasant or not possible. But when you can get it, a former laboratorian, I do say that blood is a great specimen to use when it works. Being very careful if you're using that triage approach and you're sending from like a rural clinic, or you don't have a FedEx pickup every day, it's really important to get this blood out of the door within 2 or 3 days at room temperature, because blood keeps for only about 7 days at room temperature. So we want to make sure we're getting it out and on its way. Arkansas summer heat is not a friend to DNA in any specimen form, because it really causes that DNA to unwind and makes it all funky. So we want to make sure we're keeping it inside and not throwing it in the trunk of your car in the summer. Saliva or spit kits are so common nowadays. I think most of us who have done like a 23andMe or Ancestry test are familiar with this modality. These are great if you're an adult and you're able to generate that much spit and you're able to follow these instructions. This is great if you have somebody that can't come in for a blood draw. You can actually have these kits mailed directly to the house. But it can be difficult for kids, particularly like small children, to produce enough saliva for these kits to actually generate or get enough DNA out of. And I'll talk about one significant limitation that applies to both saliva and buccal. So buccal is a cheek swab. It's what you see in like paternity testing. But we're using it a lot for our clinical genetic counseling, and it's super duper handy. And especially with COVID, we are all used to sticking swabs in whatever orifices are going to get us results. So usually this is not as scary, not as upsetting to a child as some of the other collection modalities would. But whenever a child is very, very drool producing, then this can be suboptimal. So you want to, take care to dab the mouth, try and limit the amount of drool that's being produced. So as a former laboratorian, I'm going to go ahead and put a PSA out there that if anybody is using saliva or buccal, we need to make sure we're telling our patients, don't eat before you do it. Don't eat right before you do it. Try and have a clean mouth, because it's not like we're going to give you wrong test information. But if you have a lot of other species DNA in your mouth, maybe you just ate a hamburger and then immediately did a buccal swab, it can confuse the test results so that you won't get a test result at all. So don't worry, we're not gonna like diagnose you with a cow disease, but you could come back with a specimen that wasn't usable if failed quality control. Any tips or tricks here, Erin, for these kind of specimen collection?
I always say the best time, especially with kiddos, because once they wake up, they're like eating from morning till night, is to just go ahead and test them first thing in the morning. They haven't eaten in their sleep for most people, so so that's the best time to collect, is first thing in the morning.
Great. Yes, and I think we've kind of gone through that sample collection. And again, this can be kind of a intimidating process if you're not used to it, or if your center doesn't do a whole lot of lab draws or lab coordination. But all of these kits come with their FedEx envelopes overnight, especially if you're using a commercial laboratory kit. You can request everything. It's a nice box, packs it up. You can drop it off in a FedEx drop off and it'll be taken the same day. So a lot of these are pretty simple and straightforward. So let's kind of, in our final remaining 5 minutes, talk about our cases again and really bring up our discussion. So let's say that we want to do a first tier test, a microarray, for our kid with developmental delay. And it's going to cost about $1,000, including the markup from the hospital. Down in Arkansas, if you were seen through the pediatric center, this actually would be covered when certain criteria are met. Prior authorization is available. And let's say for a kid with developmental delay that it's been approved. That's a pretty reasonable scenario. That's pretty great. But Missouri Medicaid, as kind of we discussed earlier on in our case discussion, might be a little bit more different. And so I'm wondering, in this kind of case, does anybody think that this triage care model or would work here? Or how would you kind of train, or how would you envision this working in your state? Hopefully that prompt made sense.
Julie, I know we were talking earlier about how North Dakota has, a similar model, or they're trying to use a similar model. And I know we tried to use a similar model here more consistently with that triage care. But one of the biggest pushbacks that I got from the primary cares or the referring specialists is just not having the staff to, the bandwidth in their staff to be able to do the prior authorizations at all. I don't know if other people have experienced that, or just kind of put that out there.
And Terry Jo had a great question in the chat that, is there an age limit, like a lower age limit? And I think we see genetic testing and appropriate indications for genetic testing from birth through forever. And for, something specific like developmental delay, that of course would be appreciated over time. 5 years old, 3 years old, that's a really common age of referral for that indication. But, a lot of these babies might exhibit developmental delay even in infancy. They might just not be eating correctly. They might have incredibly low muscle tone. So those motor delays or absence of babbling can be absolutely apparent early on and can be justified and covered. I can't imagine anyone would deny a microarray in a child that wasn't meeting motor milestones, even in infancy.
Yeah, and I can concur with that. Like just those milestones of like sitting up, pulling to stand, even babbling, or eating. Poor eating usually results in poor growth. So those can be some ways to justify testing in that very early stage of development.
Mm-hmm. And for case number 2, I'd love if you want to chime in on the chat or unmute and come off for a discussion. Let's talk about the very common case when we might have some out-of-pocket costs available, and we might not be able to be super specific about that. So the testing for Stickler syndrome, we might be investigating 2 or 3 genes, is about $1,200 at a list price at a lab. And because we're sending direct to the laboratory and billing insurance, we don't have to worry about that hospital markup. We're going to send it directly there. We're not sending it through our hospital. Commercial insurance has a policy and offers prior authorization. And you've submitted your information and we've gotten a prior authorization. Go us, woohoo! We've told them why this is important and they agree. The testing has been prior auth, but let's assume the family has a 20% co-insurance. So that's going to be about $240. And so with our final minute, I'm going to stop share and let's maybe just show of hands, thumbs up, thumbs down. Some families that $240 would be insurmountable, and some it might be approachable. So I guess I'm just wondering, do we go ahead and order testing? Do we bring them in and talk about it? What's this process for you guys? Erin, what would you do?
Yeah, so I would say what we typically did to handle this was we covered it by phone, when we were calling to say, hey, this authorization is in place, remind them that they have their out-of-pocket costs and it could be approximately this amount. Usually the labs that I worked with had financial assistance programs that could potentially offset even that cost, that remaining cost. And I encourage them to talk to the, because in this year direct billing, so they should be able to talk with the customer service at the lab about how they might apply for that.
Yeah, this is just a good example of we can do everything right and there still might be some financial impact. And that's why I think some of these tests and some of this insurance nuance feels maybe more comfortable in a genetics office because we're a little bit more adept at knowing the ins and outs, but this could happen, you know, for anyone's provider office. And really with any service, genetic testing is not totally unique in the fact that it could be incompletely covered by insurance. So perfect. Yep. Waiting till the out-of-pocket max is met. Great suggestion, Braden. Sometimes it's like, well, why don't we just see where we're at the end of the year? We might not have any financial liability then. You might have met your deductible. And for a lot of these kiddos, that's the case.
But
Thanks, Abigail, for putting the evaluation link in the chat. Awesome. Well, thank you all so much. Feel free to fill out that evaluation. CME and CEU credits are available, so definitely don't want to miss out on that. And thank you so much for participating and giving your insights and how this works in your area too. All right, and I think we're ready to conclude. Is that right, Abigail? Okay.
Yes.
Everyone have a wonderful day. Stay safe.
Thank you, Julie.
Thank you, Erin.
I'm going to stop recording.